jail, as well as from hospitalization to a more appropriate care in the community partners. And so within the crisis response unit, we have touched approximately 5,000 individuals by doing just that. We have engaged individuals who were unhoused. We have engaged individuals who were experiencing some type of domestic violence. We've engaged individuals who just needed the shoulder to lean on due to the fact that maybe someone in their family was just involved in some type of crime, violent crime, such as homicide. And so we have been pretty steady in the de-escalation process of the program. But along with that, working with the officers has been phenomenal. Working with St. Louis Metropolitan Police Department and their partnership, not only do the mental health providers as far as the clinicians are able to de-escalate, but because of the relationship that some of the officers have in the community with some of the individuals that we serve, they also add to that in actually rebuilding the trust with those in the community, especially with the uproar of everything that has been going on with the officers and individuals who have experienced some type of mental health illness or behavioral health illness. Now, when they see us, or they're actually calling for us, and we're actually in the community known as the folks or the people in the purple shirt. So a lot of the community individuals, residents here in the city of St. Louis, they don't say, hey, send the CRU. You know, they do not understand. And when they're in the midst of their psychosis, all they remember is the purple shirt. So we have coined the phrase, send the purple shirt. So that is basically what the purpose of our program is to de-escalate when we are called to a scene, to create some type of stabilization, to divert them to the right sources and not to jail and not the hospital. Additionally, we do provide that follow-up and care coordination services. And with that, we've been working with some of the community providers, such as Places for People, Queen of Peace. And our newest partnership is with the Community Behavioral Health Liaisons. We actually have been working diligently with them. And I believe it's 6 organizations that we work with now. And they too have been able to assist us with a diversion of them going from jail or from the hospital into the more appropriate services. And with that process, they have actually linked individuals, which is a great thing because that was the missing piece. That we are actually bridging that gap. We have not been able to provide the necessary linkage that has been needed. But because of this program and the community partners that are working with us, we're bridging that gap, and individuals are now getting all the support that they need and more. Okay, I turn it over to Lieutenant Day with what is the CRU responsibilities.
Good afternoon, everyone. As Felicia said, I'm the commander for the Crisis Response Unit. I am the lieutenant, and I'm over all the police officers who work in this program. When the CRU teams are out there on the street, they're my responsibility. As Felicia also mentioned, that we cover the whole entire city, and it's broken down in 3 areas, which is North Patrol, Central Patrol, and South Patrol. Again, Felicia stated that we work 7 to 3 and 3 to 11. So each area station per shift will have at least 1 CRU team available to respond to calls that deem necessary. People who are involved in witness a traumatic situation or a person who's going through some type of mental illness. First and foremost, we want to make sure that when my CRU teams are out there that we put the clinicians in harm's way. So if there's a call that comes out that requires a CIT call, and maybe there's a threat that maybe the person may have a gun or some type of weapon, we will not send our CRU team in until that situation is made secure. And once the district officers get it under control, a CRU team will come in and then start doing their assessments. Like again, there's no time when we will put the CRU team in harm's way if there's talk of any type of weapon, or if there's someone who is thinking about harming themselves, we got to make sure that there's no weapons there. And then a CRU team could respond by themselves, because the primary responsibility is for them to de-escalate the situation. So we want to make sure that they get in there and get to the people that need the help, but we got to make sure it's safe for them. In need of social services resources, we do more than just respond to people in mental health crisis. We deal with the homeless population, which is a big problem within the city, especially in the downtown area. So we work hand in hand with the bike units who work downtown. If someone needs, needs assistance in getting shelter, things of that nature, CRU can also help in those avenues too. So it's not just mental health. And there's really no age that we don't provide resources for. So anybody from the age of 1 to 99. So that's kind of where the CRU responsibility. There's 3 type of ways that CRU will receive their calls. One is now that the CRU teams can actually be dispatched to a call through the 911 system. Before, when the unit first started, we were kind of just on a self-initiated type basis, but now we actually have crews actually receiving calls. Sometimes they will respond on a call by themselves. Sometimes they will respond to a call as an assist. We also respond by self-initiation. Self-initiated calls are basically the clinicians and officers in the one unit will look at the calls for service, see what fits their criteria, and then just respond by that call to see if they can be of any assistance. They also receive calls by the district officers. District officers can go into a scene, find out what's going on. Once they figure out, hey, maybe this seems like something that CRU can help assist us in, they can request for a CRU team through dispatch, and the dispatch will then ask for the CRU team to go by and assist those officers on a scene. Types of calls dispatched to CRU. On the screen, it shows 8 kind of different type of calls, but we're not limited to those, but these are kind of some of the calls that we do respond on. When you look at like trespassing, panhandling, peace disturbance, these are kind of a low-level crimes. We also would like to try to respond to those type of calls to maybe divert those individuals from going to jail. Maybe we can get in there and offer some resources to help them deal with maybe the problems, why they're trespassing, why they're panhandling, or why they're creating this peace disturbance. We also go to sudden death calls because if someone witnessed somebody maybe passing, that may be something traumatic. So we make sure that a CRU team is there to help them, assist them through that troubling times. We always want to make sure we respond to all the CIT calls because of the nature of them. So sometimes CIT calls can be held or called, which is called stack calls, which is a call that's given to them. Maybe they're out of service, but it's in a queue where they can go back and go by that call later after they finish up another assignment. And we also try to get by all the suicide attempts. Of course, really offer resources in those areas. And we've recently been really active in domestic assaults. We're really starting to play a bigger role in that now in the last couple of months. So these are, like I said, these are just some of the calls we go on, but they're not limited. We're not limited to those calls.
Thank you, Lieutenant. So diversion does work. The CRU has diverted the following since February 8th of last year until present. 86 individuals of those engaged with CRU in the last year have been diverted from hospitalization. 99% of those engaged with CRU or with diverters from the jail. And I would like to add that not only do we have clinicians that's in the community, but we also have a clinician that is also in the jail, because we do realize that sometimes individuals will have to go to jail, and we do not want to negate them from not having the resources for when they are released from jail for when they get out. So they too have the opportunity to be provided those services once they are released. Sometimes individuals are released within an hour. Some are released within a couple of days. But one thing they do know is that when they are released, they will be able to get touched by someone, and they too will be able to be connected to whatever services that they need. And so in the last year, a year ago when we started, we had probably the top three were actually acute mental health disorders. We also responded to calls of, the second one was suicide, and then the third one was domestic violence. To this day, we have actually, it's kind of shifted a little bit. And the number one is the self-sufficient needs. And then the second one is behavioral response, but a low level. And the third one, as Lieutenant Day did say, is domestic violence. And so while we have seen a shift and a change, especially with the suicide ideations in response to those calls, those individuals are actually getting the support that they need. They're actually not calling a 911, or they're actually calling their caseworkers now, or they're actually taking their medication. Or even if they run out of medication, they will call the CRU, because they know the CRU is going to respond and get them back connected and get them back on whatever medication or whatever assistance that they might need in the long term. So we've actually had the opportunity to work with MasterCard, and MasterCard assisted us with looking at the different cases. And this year, 2021, we did observe over 4,000 cases that they did have the opportunity to review. And with those 4,000 cases, we actually saved the City of St. Louis officers 2,000 hours were saved during this time. We saved 900 hours of the EMS transport, and those reprioritized, and where individuals wasn't waiting for EMS to arrive to assist them when they was needed. Previously, prior to CRU, EMS was responsible for responding to those calls. EMS was responsible for going in and making the determination if that person was truly experiencing some type of suicide ideation. It was EMS responsibility. And EMS now is able to actually go and actually be available for those who are physically sick, and allow the experts in the mental health field to deal with those who are experiencing some type of clinical sickness. Because the reality is that a lot of times individuals are just simply disengaged from services, and we need to re-engage them. The hospital was not the answer at all times. Sometimes it really was, and they really did need to go to the hospital, and they did need to get reevaluated and maybe have some medication adjustment. But for the majority of the individuals, 86% did not have to be hospitalized. 86% did not have to go. We were able to connect them to services, get them the medication or whatever the therapy is that they may need, and allow everyone else to do the job that they need to be doing. And as you see, that 750 individuals, hospitalizations was averted. But the good news is this, that I would like to point out, is that we're estimating in 2022, that was just our first year, brand new program. And so in our second year, we're estimating where we will serve at least a minimum of 7,000 individuals in St. Louis City, therefore saving another 3,000 hours saved for the police, and where the police are able to go back and deal with the high-rated crimes, while we as the experts can deal with the mental health and the crisis, behavioral health, some of the traumatic experiences, the self-sufficient needs, the unhoused, because we have time to talk with them. We have time to sit and talk with them for as long as they need to talk. We can go deep into some conversations where the police does not have the opportunity to do that. But now with the police that we're partnering with, they too are realizing that sometimes someone just needs a shoulder to lean on. They just need someone to listen to what's going on. And we are able to go a little deeper with that one-on-one as opposed to police officers and the quick and I thank St. Louis Metropolitan Police Department. Truly, I thank them. And because of them, we have opened the eyes of so many people within our community. And it's because of them that we are bridging the gap. We are bridging the gap because of St. Louis Metropolitan Police Department and our community partners. And the mayor's office has received calls and where individuals say that now it is because of the CRU. Now trust has been reestablished within the community. So, where CRU ensures an appropriate response to our residents when police are dispatched and there is behavioral health need, 911 Diversion works to meet community needs and prevent unnecessary dispatching of emergency personnel. 24/7, 365 days, access to BHR's crisis clinicians on dedicated lines is what we have here at BHR. Clinicians accept all transfers and work to meet residents' needs and divert from emergency personnel hospitalization. And with our 911 call diversion program, which is also under the umbrella of 911 diversion, we will have Dr. Andrews to begin to speak on our 911 call diversion program here at BHR. Dr. Andrews.
Thank you, Felicia, so much. Tiffany, Felicia, and Lieutenant Day did a wonderful job of describing where public safety and public health work together in on-site responses to make sure that our citizens are getting both a safe and a best practice response when they're having a mental health crisis or there's mental health needs present. It's a really big deal. I tell Felicia this all the time. I have some CRU envy. When I started taking crisis calls and doing mobile outreach at BHR back in 1998, boy, if you'd have told me that I could ride around with officers and be on the front line with them every day, I would have been all over that. But not to say that is a tough job. It is not for everybody. It's not for every officer, and it's not for every clinician. There is a special thing. Training matters, but also there's some special traits that those clinicians and those officers have. And Lieutenant Day has done a really good job of helping us connect the officers, and Felicia with helping train and connect those clinicians. It works beautifully. Now, as you can see, when we talk about different prevention and diversion points, there's lots of different places where you can prevent and divert. So we're going to go a little farther upstream, right? So, hey, there is no doubt that it's really good to have these CRU members with officers on site when we need to respond. But what if we could divert a little farther upstream, right when that 911 call comes in? So that's what 911 diversion is. That allows for the 911 call takers who answer that St. Louis City 911 line, when they get a case that's appropriate, that doesn't require an on-site or an EMS response, if there's a legitimate alternative, they can then divert that away from a law enforcement or EMS response altogether, which is wonderful. Now, I like to do some level setting with this. When we had so much support and so much expertise from other cities, but from Major Larson with the St. Louis Metropolitan Police Department, Jerry Baumgartner, who's with the Metropolitan Police Department, Will Pinkney, who's with the city and a former officer. When people call 911, they have a very specific expectation. Someone is going to respond as soon as possible to their location, right? People don't, by and large, and this is where there's been some bad information out there, people by and large don't call 911 because they're feeling bad and they want to talk to somebody. That does happen sometimes. I'm not saying it doesn't, but that's a really rare event. People call 911 because they want an immediate on-site response right now. That means that the city and BHR, we had to make really sure that we made appropriate assessment to make sure that we weren't delaying an immediate response, right? So there's a layer here where, just like you heard Lieutenant Day talking about, hey, we need to make sure that our CRU clinicians are safe before our CRU clinicians respond. Before we divert over to BHR on the crisis line, those 911 call takers got to make sure that, hey, we don't need a more immediate response. So let's talk about some things that we screen out, right? First of all, if it's not behavioral health or suicide related, it's not going to get sent over to BHR, right? So the 911 call takers are trained, hey, if it's not behavioral health related, it's not suicide related, you handle these calls just like you would any of your 911 calls. Now, if there is a behavioral health or a suicide related crisis, we got to make sure Is there any present violence? Is there a weapon? Is there an immediate plan for suicide? Is there a medical crisis? We need the answers to these 4 questions, because if any one of those is a yes, diversion is not appropriate, right? We need to make sure that we match the call to the appropriate response. Next slide, please, Felicia. So look, sometimes we got to acknowledge that diversion is ineligible. And I will tell you, those of us that knew a lot about 911 calls and talked to experts, we knew that that number is significant, but it's not huge, right? So you're going to see that 911 diversion numbers are smaller than CRU numbers, because it's a much harder bar. We got to make sure that there's absolutely no need for an on-site response. So look, if it's not eligible for diversion, then the police are going to respond, or EMS is going to respond based on the nature of the situation, right? And often in those calls, maybe CRU will be involved. Next slide. This gives you a sense of, we developed these workflows. Now this workflow has been tweaked a little bit since we went live, because guess what? You keep learning and growing as you implement things. So when you look at this, the one thing I want you to see is, you can see these 911 call takers are having to make some decisions about, hey, does this work? Does this fit for diversion? Does this not fit for diversion? Is there an immediate safety issue, a medical issue? If not, then we can divert over to BHR. If so, we've got to go to the appropriate channel. Next slide. This shows you what happens upper middle when it gets to BHR. If BHR can divert it, we just take care of it. And this is what's so cool about this. 80% of the calls sent over by 911 call takers that get sent to BHR 24/7 get diverted away from an EMS or a police response. The call takers at our 911 center have a good general sense of the sorts of calls that fit for diversion and those that are going to require police response, right? BHR clinicians are really good about, once they get that call, we make sure we do everything we can to meet that person's need without involving law enforcement or EMS. So my clinicians are told, hey, when you get a call from 911, you accept it. I don't care what's coming through, you take care of it, and then do what you can to stabilize that person without involving law enforcement or EMS. But keep in mind, if we have to, we will. Now, you'll notice a couple of things about this that I like to point out. If you look at the upper right-hand corner, the lower right-hand corner, and the left-hand corner, you'll see that everything ends up being referred to 911D follow-up. That means everything that comes through to us from law enforcement, from 911s, we follow up with everybody and everything we possibly can. And just like Felicia was talking about with her team, our investment in our assistance doesn't stop with that initial response. We keep doing follow-up, make sure they're getting connected where they need to get connected to. Next slide, please. When we, the other thing that's been really helpful is that as part of the city's efforts, we're doing a much better job in identifying calls that are behavioral health related. So there's a whole list of new codes that, and believe me, this is a huge, huge thank you to the 911 professionals, the EMS professionals, law enforcement, all the coding folks, because when we came in, we had to change a bunch of stuff of how we do things. We now track things in a very different way than we used to. So there are now things called CIT related calls. Makes sense, calls that have a behavioral health component. This CIT behavioral health non-crime related, there's an entire code in the 911 comm system called the CAD, if folks want to know, that literally says, hey, the dispatchers, the call takers have identified that there's no crime going on here. This is behavioral health related and there's no need for an immediate law enforcement response. Let's get that over to the crisis professionals, right? So we have a nice general definition here that basically says, hey, if a person is having an emotional crisis or has emotional needs and they're not in immediate medical jeopardy or dangerous to themselves or others, if we can talk to them first, let's talk to them first. Just like Felicia was talking about, when we get on scene, we can spend some time figuring out what's going on. One of the best things we've learned about de-escalation is slow the process down. Slow everything down. One of the best things that happens when people get sent over from us from 911 is my clinicians, our team's going to slow that down. Let's find out what's going on. Let's get more detail. Let's start talking. Next slide. Here's things that we do. Once that call comes over to us, we've got 24/7 phone response. We can send our own mobile outreach team. If we feel like there's a psychiatric crisis, we don't need CRU, we don't need police, we don't need MS, we'll send our own team out. We get people next day urgent appointments. We have alternative services, and we follow up with every single person we can. Next slide. We follow everyone who accepts follow-up, we follow up with, and our acceptance rate is pretty good. Any client, so one of the cool things that we do, and BHR is in a unique position because we can literally access and see where folks are connected in the system of care if it's connected to the department, Missouri Department of Mental Health. So one of the things we're going to do is we're going to see, hey, is this client active with any agencies? Here's what's interesting. And I think, Felicia, you may have commented on this already. About 30% of the calls that we respond to are active clients. They are already hooked up with an agency. Now, one of the messages that we're working on is we need to work with our agencies to be doing better crisis intervention at the front end, because a lot of this stuff can be, I'm sorry if you're a provider in the community, close your ears if you don't hear this. A lot of these calls to 911 and for law enforcement could be prevented completely with a little more upfront crisis planning and crisis prevention plans at the front end, right? So anybody that comes through, let's say we look up and caller A is connected to agency B. Guess what? We're following up with agency B and we're saying, hey, your client is calling 911 for crisis services. Can we take care of that? Can we find a better way to handle that? The agencies have been great. Anytime we're unable to divert somebody, so anytime we have to follow up with law enforcement or EMS, we're doing follow-up. We do follow-up. Not only is follow-up a best practice. When you follow up with people, they feel cared about, they feel more important, they're more likely to connect with services, you're more likely to de-escalate. And even more importantly, we get data about the impact of our services, right? So when we follow up, we can say, hey, did you get linked with services? If you didn't get linked with services, what were the barriers? What can we do? Let's call around with you. Let's open some doors. Let's work on this, right? If you're linked with services, is it working for you? Is this all the services that you need? Is this working? Great. Have you had to use emergency services in follow-up? Have you had to use the hospital since we've helped you the first time? So we want to see, is what we're doing working? Next slide, please, Felicia. Here's our 911D big outcomes, because there's lots of outcomes, but these are the big ones we're going to focus on. 80% of the calls that come in from call takers are diverted away, no police or EMS response. We love that. We're reaching about 54% on follow-up. About 34% are linked with services post 911 call. Now, I would love that number to be 70, 80, 90%. But keep in mind, prior to 911 diversion and CRU, it was zero. Like nobody was getting linked with services. Literally, people are now calling 911 and they're getting help, getting connected with more appropriate care. 80% of the folks that we're in follow-up with are diverted from additional psych services, and 90% are diverted from additional law enforcement or EMS responses, right? So what we're showing here is that you can't divert everything, nor is it appropriate to divert everything. There are legitimate and important reasons why we need law enforcement to respond or EMS respond. There's very legitimate reasons for people to go to the hospital. But we want to make sure that we match, and Felicia did a good job about talking about this. We want to match the need with the most appropriate response. And the combination of CRU and 911 diversion has really allowed us to better match needs with appropriate responses. That's a huge, huge change. Next slide. This is one sample of about 20 different screens of data we collect. I'm not going to go through all this. It's just to show you part of what we're doing. My team, Felicia's team, overall BHR, the city as well. We're collecting tons of data, learning more and more all the time about what we're doing, and then we're making adjustments based on what we're learning. Next slide. Felicia mentioned that the MasterCard Test and Learn team did an external independent evaluation of the program's impact. This is just specific to the 911 diversion part, the 911 call taker sending calls over to BHR. And you can see, although the numbers are lower, the impact is still really big, right? We handled over 607 cases, 450 hours saved, 650 police dispatches reallocated. Think about that. That's 650 police responses that were able to respond to something else that was more appropriate for a police response, right? EMS transports reprioritized. We're in 120 hospitalizations diverted. We're keeping people away from expensive services. We're keeping those EMS ambulances free for more appropriate services, and we're keeping people out of the hospital unless they absolutely need to be in the hospital as best we can. And you can see that when we look at the 2022 estimate, we expect that to go up substantially as well. So we're really excited. We couldn't do this without the city's partnership. I cannot tell you how much work the police and communication staff and support staff have had to do to support this effort. BHR works really hard. The law enforcement and the administration have worked twice as hard to get this up and running. So thank you. That's my spiel. Felicia, Tiffany, Lieutenant Day, anything I forgot or missed that you think we should comment on?
No, I think we could just open it up for questions.
I have a question.
Sure.
That's all right. Hi, everybody. I'm Kelly Dunaway. I'm a councilwoman on the St. Louis County Council, and I'm working with some community leaders in the county. And Polly, I saw your name down there. Polly's on my work group, and we want to do something similar in St. Louis County. But our work group really wants to have not a co-responder model, but just a non-police first responder program. And I wanted to learn from you guys, like, what made you decide to go the path of the co-responder model? And do you have any gut reactions or like, ooh, tales of caution or anything that you think that we should be considering? And also, I'd love to like huddle with you at another time where we could really like get into this more, but just co-responder model versus non-police models.
Yeah, so I think one point of clarity that we didn't talk about is the future of the expansion of the program is to add just that non-police response. So we'll have just a clinical team showing up to divert some of those folks in a different way. I think for us, and then I'll let the rest of the team kind of speak to your point. I think for us, what we wanted to do, and I think the most beneficial impact is to start with that co-response with the police department, because what you really want to divert is not just the hospitalizations and the criminal justice intervention. You're really trying to get the community to get back into community policing and that dual relationship of trust. And that's what we've been able to do. I think having an opportunity to work with the police department, what we also have found really quickly is that we're all working on some of those really difficult cases at the same time. And they're trying to figure out how to work with those folks, and we're trying to figure out how to work with those folks. Having that input has been really vital for us to move some of those folks to the appropriate level of care. And we would not have been able to do that without the police. I say that as a provider, even outside of BHR, having to work with these people for many, many years, and then stumbling into this program and figuring out, hey, you guys have been trying to work with them too. And having that partnership be able to pull together and get them finally to the right place of care, the right level of care. So I don't think that you can kind of work around having that police partnership. And I really don't think it's beneficial to start that way. I think it's the most benefit and the most bang for your buck is to start with that police collaboration and then expand into that non-police response.
So I definitely want to hear from Lieutenant Day and Bart. I'm curious, is there a way to have a collaborative program with the police? I mean, because the reason I ask is because when I talk to police officers, they don't want to respond to a lot of this stuff, and unless they're in the CIT program, but they signed up to solve crime and to keep neighborhoods safe, and they'd rather someone else go anyway. And so I'm just wondering if you can get the buy-in and the collaboration and the support to work with the police department without having a co-responder model first. I don't know.
So I think about it this way, and this is kind of how I've always thought about it, and I don't want to monopolize this whole conversation, so I'll jump in, but what you're trying to do, and the whole goal is to change two cultures. You're trying to create a third culture, because as a behavioral health provider, I can assure you that our culture needs to change as well. Right. So just throwing more behavioral health resources is not the solution that we're really looking for. What you're looking for is for us to figure out how to collaborate and create another culture, because whether the police department wants to respond to it or not, they do respond. And what better way to make sure that they're trained to actually respond to those things than to have this kind of a program be implemented and embedded into the culture of that organization as well. So I don't think you can get away from it, but I will open it up. Dr. Andrews.
Tiffany knows where I'm going to go. I have very strong feelings about this, so I won't be shy. If you don't do the co-responder model, you're eliminating a huge chunk of cases that you will have no contact with. So I think what's interesting is when you look at where there's challenges with law enforcement and the community is not in the cases where there's literally no violence present, it's when there's the potential for violence. When you look at the STARS model and the KUDOS model, beautiful program, STARS in Denver and KUDOS in Oregon, they're wonderful. They do not respond to the things that CRU responds to. They don't come anywhere near it, right? To Tiffany's point, you start siloing. The officers, so here's a Lieutenant Day, and he may have feelings about this. An officer that tells me that I have no interest in helping people that are having a mental behavioral health crisis, I didn't go into law enforcement, that's a system and a training problem. That's not acceptable, not even remotely acceptable. We should not enable that attitude. I can't state this more strongly. That's not a public safety attitude. That's a soldier's attitude, right? We don't need soldiers. Soldiers serve their purpose in other places. We need public safety officers. Public safety includes dealing with these sorts of situations. So Lieutenant Day, I'm sure that you might have something to add to this. Please chime in.
And then Lieutenant Day, you'll be our last comment because we're at the end of our time.
Okay, just to piggyback on what Bart was saying, yes, as the speaker on behalf of the police department, there's a culture change that's going forward. Hey, the days of just, hey, I'm out here just to lock up bad guys. That's no longer the case. So there's a cultural change that our police department is going through, and the city has set the pace, and we're catching on, and BHR is playing a big part in that. So yeah, there is a cultural change, and you're going to see that moving forward with this program.
Okay, thank you very much.
Yes, thank you. We are technically out of time because I did promise our speakers that we would conclude at 2 o'clock, but we do have a couple of 3 questions in the chat box. If anybody has, another 5-10 minutes, it's up to our speakers.
Yeah, I'm happy to stay on.
That's fine.
I'm happy to stay
You're
on.
Good? You're good? Okay.
Fine.
So if there are any other questions, please put questions in the chat box. We have 3 questions already, several. The first one is, when you refer to domestic assault or violence, is that only in reference to intimate partners, or does it include individuals living in the same residence?
That is correct. It does not just include intimate partners, but also involves anyone who's in their residence. And the increase has actually not been with the intimate partners, it has been with other family members within the same home.
Okay, thank you.
Yep.
And Pam, same person has another question. Bart, when you say your team slows things down to find out what's going on, what resources do you use? The individuals involved, police, neighbors, family members, police reports?
Yeah, all of the above. So the clinicians get trained in there's a list of best practices that we train our crisis clinicians in. The cornerstone of that is find out what's going on, make a connection with the person, get a good understanding, keep people talking. And then as you're getting a better understanding, then we can start kind of fine tuning to figure out what interventions do we need, right? There are some people that literally just need to kind of talk and just be listened to. Some people need more direct interventions. We might have to do some brief interventions with them, short-term coping strategies. People who are thinking about suicide, there's a evidence-based practice called collaborative safety planning for people at risk of suicide. So there's a practice that we use to improve their safety in a collaborative manner. We use a lot of motivational interviewing type of approaches so that we're validating people, hearing them out. The goal here is remove judgment, get as close to the person as you can, get as much information as you can. And what you tend to find is that when you take care of people in that fashion, they tend to calm down. And then you can start looking at some of the immediate. The other thing about this that's really important, we only focus on right now, right? You cannot, some of these folks that are calling have lifelong problems that you cannot fix in a phone call or in a CRU response. Let's focus on the short term. Let's focus on what we can do for you right now. And then we'll connect on other things. Second thing that's really important, telling people, we're not leaving you after this phone call. We'll call you back tomorrow. What's the best time to reach you? There's nothing quite as de-escalating as when folks know, hey, we don't got to solve this all tonight. Let's talk again tomorrow and see where we're at. So those work really well. Felicia, something you might add for your team that they do?
No, you hit it on the nose. Billing report immediately. It has worked. When the clinicians and the officers go to the scene after it's being cleared and secured for them to go, it just gives a comfort. It's something about the purple shirts, to be honest, from what I've heard from officers as well as the individuals within the community, it's something about the purple shirts that just creates a calmness. And they approach it from the stance of, what do you need? What can we do to help you? They don't ask what the problem is. They said, what do you need? How can we help you? So that approach has helped. And of course, the de-escalation tools, of course, they go through motivational interviewing, all the different trainings. And I think one of the key things that I found to be helpful, and Lieutenant, you can speak to it as well, is that our clinicians and our officers, they train together. So they actually meet quarterly and we do all day trainings together. And so we will not miss a beat because we are one unit, whether we're training on mental health components or if we're training on something relating to the police, they're together and we spend time together because we're one unit, we're family, we're partners. When my clinicians are in the car with the officers, it's not like they are just civilians. No, that's their partners. They look out for one another. And so when the community see that, quote unquote, civilians in the car with an officer, it creates a calmness and they are at rest and at peace. And opens the door for us to do what we do.
I would just say, when we go out and recruit officers or when officers request to come into the unit, that's the first thing we preach. Hey, this is you guys are going to be teams. This is a team program. And when we have our training together, we embed that in them. Hey, you're a team, you're a team, you're a team. Hey, we call it, I got one of my sergeants calls it a marriage. Hey, if you guys have problems, you need to work them out because you are a team. Yeah.
Thank you very much for those responses. One thing that's really sticking out to me today is that I understand that the city 9/11 system receives around 700 to 750,000 calls every year. And I'm thinking to myself how important the 911 dispatchers are and needing the skills, to discern what is a problem, what isn't a problem. And then, the ability, using the discretion to decide what goes where. How are they trained in I imagine it's a very stressful position too. So anybody want to comment on that?
Dr. Andrews?
I'm glad Dr. Andrews, go for it.
Here's one of the things, and this is something that is a good lesson for all of us. 911 call takers are experts at what they do every single day, right? And so one of the things that we learned from working with 911 is you guys tell us how to do this, what works, what doesn't work, right? And so it's incredible. When you handle as many calls as these 911 call takers handle, right? They get incredibly skilled at kind of putting these different calls in different categories, right? And so what we did is we just provided some language so that we were all talking about the same thing because they already had a sense of what kind of calls these were, right? So we just added some language so that we were all using the same language, came up with some categories that everybody agreed on. We also, we learned about some things from them in terms of what works for them and what doesn't work for them. So what we did is we created some trainings. We actually listened to calls, right? We went into the comm center and listened to the 911 calls, which was incredibly informative, right? Felicia and I listened to a bunch of calls. A couple of things stood out. One, they're amazingly skilled at what they do. We're asking a lot of them. And two, we needed to find ways to make it work better for them, right? They need a really quick handoff. You don't want your 911 call taker waiting forever to get that call. So making sure the amount of information they have to give us is a bare minimum. We don't get tons of information from these call takers. We get like 3-4 bits of information. and the clinician then has to take the ball and run with it, right? They like to know what happens, right? So we try to build in some feedback loops so they know what's going on. We created about a 2-hour training. We hit all the 911 dispatchers, and we had to do this during COVID. So keep in mind, we would have done this in a much different way if we hadn't done this during COVID. So we did some digitally, but we went to the continuing education trainings. We hit all of the call takers over all the different shifts, which was an incredible investment by the comm center, by the way. That was really hard to do. And now we try to get folks with retraining and on their when they're bringing in new folks. And in fact, we're getting ready to go start going back out there again the next couple of weeks to do some refresher trainings and update folks. So it's an ongoing process. They teach you just as much as you teach them. And that's one of the things when working with law enforcement, that we really have to respect their expertise. They know how to do their jobs, and they have really good ideas on the best way to help us do our behavioral health end of the picture.
Oh, thank you. I think we'll have to probably let you go. I know people are dropping off because we've exceeded our time and everything. I apologize deeply for the spamming incident that happened today. It really interfered with our flow, I would say. Anyway, thank you to all of you speakers who work so hard for our community and who have so graciously taken time away from your very busy schedules. And I also thank those who tuned in to learn more about this really wonderful, innovative program. And we thank you very, very much. So,
yes, thank you for your time this afternoon.
And thank you
for inviting us.
Thank you all.
Bye.
Bye.
take care out there. Be safe.